So Caitlin and I are going to moderate our first session today. And I introduced myself yesterday, but I'll give Caitlin a minute to introduce herself.
Hi, everyone. I'm Caitlin Marin, an infectious disease physician at Emory University.
Okay, so this morning, our first session, we're actually going to be leading off with a tremendous talk from our colleagues at the National Institute for Child Health and Human Disease, and who are going to give an overview. And so I just want to introduce you to our speakers. If you haven't met Denise Russo yet, please introduce yourself to her before you leave today. Denise is a force of nature at NICHD and is absolutely legendary for supporting early career investigators, mid-career investigators, senior investigators, everybody to push their research forward and get it funded. And so it's really a pleasure to have Denise here today and have her give this talk. She's going to be joined by her colleague, Gretchen Buckler, who's a little bit newer to NICHD, Gretchen joined in July of 2022. So Gretchen's research interests are in HIV and tuberculosis treatment in pregnancy and in children, also in infants exposed to COVID in utero, and the resurgence of syphilis and its effects on infants' transfusion-related infectious disease transmission and laboratory test development. So between the two of them, you have an absolute plethora of expertise about science and about NIH, and so get your questions ready for them. Denise and Gretchen, thank you.
So I'm going to orient myself a little here and make sure that I know which button to push. I guess that's not it. Okay, there we go. All right. Sometimes I learn quickly. Other times I lag behind a bit. So thank you for being here this morning. And thank you so much for inviting us, because you know we're advocates for women's health and women's research, early stage investigators and all investigators. And at NICHD, we have an open door, and we welcome you to call and speak to us about your work. And as I always tell people, if we can't do it, if we can't help you with it, we will find a person at another institute or another way to make sure that your work is heard. So I'll leave that at that and tell you I'm the deputy of the MPID infectious disease branch at NICHD. And I'll give a quick overview, and then I'll turn the talk over to Gretchen, who will discuss the research interests and progress that we've made. And I want to bring up someone else that you know, Samantha Calabrese, who is our analyst. She wasn't able to join us today, but she was instrumental in the development of the presentation. So I want to briefly highlight important positive changes in leadership at the NIH. I want you to know that women now occupy 3 important directorships at the NIH, and 4 if you include NCI, and there are others that are coming. So this is Monica Bertagnoli. She was named the 17th director of the NIH and the 2nd woman to have the title. I don't know if anyone in the audience knows who the first woman elected to that. That was Bernadine Healy in 1991. So our next special person is Jeannie Marazzo, who was named the NIAID Institute Director this fall. Her interest is now in all infectious diseases, as she mentioned, but she will continue to have an interest and advocate for women's concerns. So this is Dr. Diana Bianchi. She was named the NICHD Director in 2016, and she spearheaded efforts on the NICHD strategic plan, which we are following today and which is being refreshed as we speak. So just to have movement in this talk, I will bring in all of the different aspects of our strategic plan and show you that development is probably the most important part. It underpins all of the other parts of the strategic plan, including reproductive health, what we are interested in, healthy pregnancies and lifelong wellness. We look at child and adolescent health, transition to adulthood, which, as you know, is important in our HIV studies especially. And let me just rearrange my stuff. And number 5 being the safe and effective therapeutics and device development for all people. So let me tell you a little bit about our branch. Dr. Sonia Lee is our branch chief, and we support domestic and international research, including training and career development related to HIV in all people. As other infectious diseases have appeared or again reared their ugly heads, we have pivoted to include studies on Zika virus, cytomegalovirus, COVID-19, for example. And we study these infectious diseases, some congenital, across the lifespan. We have special interest in infectious diseases that affect women. There is really no way to approach the themes of our strategic plan, our Institute's strategic plan, without looking at and focusing on women and infectious disease. Although infectious disease is not listed as one of the main strategic plans, it cross-cuts everything. So this will show you our branch themes, and we have shown how the strategic plan integrates with the themes that we focus on in the branch. I won't read it. We will make the slides available to you. And so this is to show you that we have, in fact, studies in at least 68 countries globally, and they include studies on HIV and non-HIV areas. So, as I mentioned, we are a very collaborative group, and we count all NIH institutes and HHS among our most valued partners. We are collaborating with Peter Perrin, who's here in the audience at NIDDK, on a DP1 Catalyst Award for early stage investigators. And it explores HIV comorbidities, co-infections, and complications. There are 2 remaining receipt dates, and we've had our first review this week, and I think it really is a good opportunity for everyone to think about. We also collaborate with Joanna Rowe at NIAID on the AWARE program, which is American Women Assessing Risk Epidemiology. So we encourage research and data science approaches that have the potential to change the lives of children, adolescents, and women at risk for HIV from birth through reproductive age and adulthood. And with that, I will now turn the talk over to Gretchen, who will continue with progress and an overview.
How do I make them go forward? Oh, okay. Okay. Good morning. I'm Gretchen Buckler. As Denise said, I'm a medical officer in the Maternal and Pediatric Infectious Diseases branch at NICHD, and I'm very happy to be here, and thank you to everyone for coming and to the organizers for allowing us to be here and share NICHD's commitment to women in HIV research. Denise already described 2 programs that we support, and this slide just goes over a lot of the other research programs that NICHD supports that are cross-cutting NIH HIV research programs. As you can see, we support critical infrastructure programs like the CFAR, clinical trials networks such as the ATN and the IMPACT, large cohort studies such as FACS and the MaxWise combined cohort study, and then some other studies, 2 of which Denise mentioned already, AWARE and the Catalyst Award. This slide is just to show kind of the roadmap for how we got to two of our cohort studies that are very important, STAR and HOPE. STAR was the first study that started, and it looks at women of reproductive age living with HIV and living without HIV, and it focuses on 5 sites in the southern US, and it works sort of within the MaxWise infrastructure. And the other program is HOPE, and HOPE works in 12 sites geographically that are diverse across the United States, as well as Puerto Rico, and it looks at women living with HIV, including some who were infected perinatally, and it is within the FACS infrastructure. You all have already heard in detail about the STAR program earlier yesterday in a wonderful talk by Liz Topper. And you saw this map, and this map is nice because it overlays the STAR sites with the prevalence of HIV in the southern part of the United States. And you can see how they're located in areas where there's high need for this kind of work. And it bears repeating how well they've been doing with recruitment. As you can see, they've recruited already 140 women total. 60%, or 507, are women living with HIV, and 40%, 333, are those without HIV. And they've already completed over 2,000 study visits in 31 months. And also, as you can see, there are numerous STAR-sponsored grants and enrollment collaborations, which will give you an idea of the excellent outreach they have done and the response from the scientific community. And in particular, NICHD is very thrilled to have so many early-stage investigators involved with projects. And another thing they're doing that's very innovative with STAR is coming up with ways to enhance recruitment and retention. And these are just a couple pictures from of the mobile units they use. The top one is used at their Miami site, and the bottom one at their Atlanta site. And this way they're able to go out into the community where the participants live and work, and it makes it easier for them to reach the people where they are. And this slide takes a look at the beginning of the HOPE study. And so it started within the FACS program, the Pediatric HIV/AIDS Cohort Study, and enrolled 3,500 SMART caregivers. The SMART study is the surveillance, it's so tall. The SMART study, which looks at HIV exposed but uninfected youth. And so they enrolled 3,500 of their caregivers. And then the HOPE study, which was awarded as an R01 in 2020, enrolled women both from the caregivers from the SMART study as well as from the AMP study, which is the Adolescent Master Protocol, which includes perinatally infected women. And the HOPE study is the health outcomes and pregnancy exposure to HIV and ARVs, and it's designed to evaluate the health outcomes of women living with HIV over time. The women in this study complete online surveys, clinical assessments, and interviews, and they have a blood draw and other samples collected at the time of enrollment, and then they have yearly medical record extractions that are also completed. And my slide's already a little out of date because since I made this slide, there's actually now been 413 women enrolled as of December 5th. And as I mentioned before, they're enrolled at 12 sites in the US and also in Puerto Rico. It enrolls women ages 18 to 39, and those who have never been pregnant, who are pregnant and recently delivered, as well as women that are postpartum, some particularly within their first year postpartum, and others that are beyond 1 year postpartum. And you can see from the pie chart some of the research interests within the HOPE study, such as co-infections, sexual and reproductive health, mental health, and substance use. This slide is just to give you a little bit of an overview of the demographics of the participants in the study. As you can see, almost 3/4 are Black African American, as well as non-Latinx. We have a pretty good age range across the enrollment, so there's a few more in the less than 25-year age group, but pretty good within all of the groups. And then within the pregnancy or the participant enrollment categories, almost half are more than a year postpartum, but we also have good numbers within the nulliparous, pregnant, and recently delivered groups, as well as those within 1 year postpartum. And one nice thing about HOPE and STAR is that a lot of their data is harmonized, and it's also harmonized with the data that's in FACS and within the MaxWise combined cohort study. So you can look, so they can be looked at together. And they also have overlapping sites as well as overlapping interests. So you can see the pie chart on the left. On the left is hope, and on the right is star. And as you can see, there are a lot of things that match up, like mental health, substance use, co-infection, sexual and reproductive health. And so, as you can see, the topics synergize, and since they have harmonized data, they can work together. On another issue, we have, within other large projects that are supported by NICHD, there are a lot of other projects that focus on HIV and women. I'm certainly not going to read all of these, but they're within some of our big networks, our ATN, our Adolescent Medicine Trials Network for HIV/AIDS interventions, and one of the new protocols is the HAPPY protocol, which is HIV and pregnancy protection in youth, and that's using a discrete choice experiment to look at the values and preferences for a long-acting, multi-purpose prevention product to prevent both HIV and pregnancy, and we're looking not just at cisgender women, but also transgender men and non-binary people with childbearing potential. The PATCH and PATCH-In also have studies looking at women in HIV predominantly globally, and then the IMPACT Network, the International Maternal Pediatric Adolescent AIDS Clinical Trials Network, does a lot of clinical drug trials. So IMPACT 2040 is a phase 1/2 study on the pharmacokinetics of long-acting injectables in those who are pregnant and postpartum. Additionally, we fund individual studies on HIV in women. For example, Dr. Maskew has a study looking at the South African National HIV Pregnancy Cohort, and they're looking at continuity of care among women living with HIV. And they have had a hard time tracking the women. Sometimes after they give birth, they travel to other parts of the country, or their infants might stay with their mother, and so it's harder to track where everybody is. But they found a way to look at laboratory ID data so that they can track them when they get laboratory tests done in different parts of the country, and they can connect the mothers and the babies that way so they can follow them both. And then another innovative study by Dr. Poteat is looking at enhancing PrEP outcomes among Kenyan adolescent girls and young women. And they're using a novel pharmacy-based PrEP delivery platform because they found that about 40% of Kenyan women access their family planning products at pharmacies and not within the clinic system. And so they weren't being reached in the clinics for PrEP. And so their idea is to look at reaching them in the pharmacies where they're already going for their family planning products. So other than supporting putting out money for projects, we also have other women and HIV-oriented activities that NICHD is involved in. NICHD has representation on the NIH HIV/AIDS Executive Committee, Coordinating Committee for Research on Women's Health, Women and HIV Working Group. And that group is meeting to pull together some really interesting things. So there's an NIH request for information on research opportunities related to HIV in women, and the link is on the slide, which you guys will have access to. But it's still open right now. It's open through the end of the calendar year, through the end of December, and so we encourage you all to go and make comments on what you think is most important for HIV in women research and what you want NIH to focus on. We have a planning committee putting together a Women in HIV workshop that's going to be held on March 21st and 22nd in 2024, and it's going to be virtual, and it's going to bring together not just researchers, but community members. So each of our topics is going to have researchers talk about the research in the area, as well as have community members talk about how it affects their group personally. Yesterday, we all heard Dr. Stewart talk about the antiretroviral pregnancy registry, and NICHD has representation on that as well. And then we also work with PregLac. NICHD has its own committee on PregLac, which is pregnancy and lactation, and as everyone here knows, a lot of medications used in pregnant and lactating persons were never truly investigated or tested in people in those cohorts. And so this, we put out earlier this year a request for information to ask people which drugs, vaccines, dietary supplements get used a lot in pregnant and lactating women, and which ones they feel are the most important to have more studies done to make sure they're being used safely. And that closed actually at the end of September, and we're just now in the process of starting to review the responses we got. This is a nice long list of all the funding opportunities that my branch, the Maternal and Pediatric Infectious Disease branch, funds. And as you can see, highlighted in yellow is the Catalyst Award that Denise spoke about earlier. And as she mentioned, there's still 2 receipt dates left for that, May of 2024 and May of 2025. So if anyone's interested, make sure they look at that one. And then this is another thing that NICHD supports. It's DASH, it's the Data and Specimen Hub. And this is a centralized resource for researchers to share de-identified data from studies funded by NICHD. It also functions as a portal for requesting biospecimens from selected studies that are in the DASH hub. So as of January, there were 207 studies on 54 study topics, and as you can see on the left, that's an example of some of the study topics that are included. There are also 9 studies that offer biospecimen, and on the right side of the slide, you can see the wide variety of biospecimens that are available. And it's actually being used, which is the point of it. So there's been 581 data requests already, 12 biospecimen requests, and there've already been 83 data use publications from it. And this is just a final slide to learn a little bit more about NICHD. There's a link to the Maternal and Pediatric Infectious Disease Branch newsletter, which has highlights of what's going on in our branch and research that we funded. NICHD also has an Office of Global Health, and they put out an international activities catalog, so you can see what parts of the world we're working in. On our webpage, we also have a Get to Know Profiles section, and you can look at the profile for Dr. Sonia Lee, who Denise mentioned as our branch chief, as well as Samantha Calabrese, who, as Denise also mentioned, was instrumental in getting the slides put together. Hopefully most of you know that we now have a brand new NIH data management and sharing policy that went into effect in January 25, 2023, so that any application submitted after that date now needs to have a data management and sharing policy. And this link will take you to the site. It has examples of what needs to be in the plan and resources for how to make sure you're including everything that needs to be included. We also have an HIV/AIDS health webpage that you can just learn more about everything NICH is doing. I've mainly mentioned things that our branch does, but there are HIV initiatives within other branches at NICHD. And just a plug for the Office of AIDS Research has an early career investigator resources webpage, and that has access to grant opportunities and other resources such as training and capacity building programs. And that's it.
Great, thanks so much. Our next speaker this morning is Dr. Rebecca Abelman from UCSF. She's an infectious disease physician, HIV primary care provider, and clinical instructor in the Division of HIV, Infectious Diseases, and Global Medicine at Zuckerberg San Francisco General Hospital. And her research interest is in the progression of aging-related comorbidities among women with HIV across the reproductive lifespan, with a particular interest in cardiometabolic and pulmonary disease. And she'll be speaking with us this morning on sex differences in aging and inflammation.
Hello, everyone. Thank you so much for having me. And I'm very excited to be talking about sex differences in aging and inflammation this morning. I'm also going to be talking about one of my favorite topics, which is menopause. So I have grant support from the National Institutes of Health, but no other relevant disclosures. And I know we've seen this slide multiple times, so I'm going to keep it brief. But as I'm sure everyone in this audience already knows, over 50% of people with HIV are over 50 years of age. And in 2021, women represented 18% of the new HIV diagnoses in the United States, and 41% of women with HIV in the US are over age 55, and so women with HIV are aging in the United States. Internationally, girls and women make up more than half of people living with HIV. So as Dr. Lahiri also mentioned yesterday, there are many sex differences in aging-related comorbidities in people with HIV. So there have been many aging-related comorbidities that have been reported to be higher in women with HIV as compared to men, including cardiovascular disease, so non-calcified plaque, higher HIV attributable risk of MI and ischemic stroke, lung disease, bone mineral density loss and fracture, and then certain neurocognitive metrics such as learning and memory. And this is a slide that's taken from a really nice review by Marcus Adfield and Dr. Eileen Scully. And there are many different mechanisms that are purported to be why there are sex differences in HIV infection, including acquisition, ART-treated disease, pathogenesis, and differences in the HIV reservoir. And I'd like to argue today that it's the increased immune activation that is seen in women with HIV that underlies a lot of these mechanisms. So why would that be the case? So women have a stronger innate immune response to HIV than men. So I'm going to talk briefly about plasmacytoid dendritic cells, or PDCs, and TLR7, or toll-like receptor 7. So TLR7 is encoded on the X chromosome and is expressed on the membrane of PDC cells, in addition to B cells and to a lesser extent monocytes and macrophages, and it can sense HIV ssRNA. And that activates NF-kappa B as well as TNF-alpha, and it is one of the most potent, so TLR7 is one of the most potent producers of TNF-alpha, which then leads to production of inflammatory cytokines. The figure here on the left is from Meyer et al. From a paper in 2009, where she looked at PDC cells and their response to HIV-encoded TLR7 ligands, and you can see that women had an increased interferon response as compared to men with HIV, which may explain why women have lower viral loads than men and higher inflammation at any given viral load. And why would this be the case? So female cells express more of the innate immune sensor TLR7. And that is because the TLR7 gene is encoded on the distal end of the X chromosome, which is epigenetically silent. Recent studies have suggested that there's incomplete silencing of the X chromosome, and that leads to incomplete inactivation, also known as escape. And that's actually one of the purported mechanisms for why there are a lot of sex differences, because it can cause extra gene expression of some of these proteins that are on the distal end of the X chromosome, and that includes the TLR7. So escape from the distal X chromosome in female PDCs may result in increased TLR7 protein production and mRNA production. So here's just a schematic of this. So this is the male cell, and you can see the TLR7 mRNA on the distal end of the X chromosome. And in response to viral RNA, you can see a moderate type 1 interferon response. Whereas in the female cell, due to incomplete X inactivation, you can see that in response to viral RNA, there may be a stronger type 1 interferon response, which may provide a mechanistic basis for higher levels of inflammation in women than men with HIV. So how is this borne out in studies? So I'm going to highlight there have been several studies that have found higher levels of immune activation biomarkers in women with HIV as compared to men. But I'm going to highlight this recent study from Streak et al. That was published in 2022. And here you can see in the figure, this is from the Africos study cohort, that in HIV negative participants, that there were no real marked sex differences in immune activation biomarkers. Whereas you can see here with the dark blue, with those who had HIV, there is a notable sex difference, and I want to mention that all of these are virally suppressed individuals. So you can see that in treated HIV, women had higher immune activation biomarkers when compared to men. And I want to highlight CXCL10, which is also known as IP10, which is an interferon-inducible protein, which corresponds mechanistically with increased TLR7 activation, leading to increased interferon response. So in summary, elevated immune activation in women with HIV may be a driver of sex-specific differences in clinical outcomes. So systemic immune activation inflammation is implicated in the pathogenesis of aging-related comorbidities in people with HIV. And for many of these comorbidities, there are sex-specific differences in their progression and development. And so that women with HIV have higher immune activation levels may be one of the drivers of some of these sex-specific differences in clinical outcomes. So I'm going to show a little bit of evidence, hopefully, to support this. So I want to highlight the work of Dr. Sam Schnittman, who was working in the CNIX cohort, and he's now based out of Harvard. And he, and along with others, presented this work at CROI in 2021, looking at a sub-cohort of the CNIX cohort. And after adjustment for age, race and ethnicity, smoking, Hep C, injection drug use, ASCVD score, nadir CD4, and CNIX site, and notably all of these participants were virally suppressed, you can see that there are several immune activation biomarkers that were higher in women than in men. When adjusting for VAX index, which is a composite score that's been associated with increased mortality in people with HIV, looking at a composite endpoint, including type 1 MI, ischemic stroke, venous thromboembolism, and death, you can see that there are some immune activation biomarkers that may more strongly predict certain this composite outcome, these clinical events more strongly in women than in men. And what I want to highlight is that specifically IP10 was the most significant interaction, the interferon-inducible protein that we also saw in the Streak et al. Paper. And then also CMV-specific IgG titers were more strongly predictive in women than in men. So now I'm going to shift to talking about menopause and HIV. So how does aging play in all of this? So as many of you may already know, menopause and HIV are both associated with a higher comorbidity burden. So in the general population, menopause accelerates the onset and progression of many chronic diseases, including increases in body composition, decreases in bone mineral density, and increases in neurocognitive changes. And women with HIV may be particularly vulnerable to changes during the menopausal transition. So there's evidence to suggest that they may experience menopause at earlier ages. And then in a work by Lauren Collins, who is here today, that in an analysis from the Max-Wise combined cohort study that of US-based women with and without HIV, menopausal status, age, and HIV were all independently associated with a higher burden of aging-related comorbidities. So this is just a schematic or a theoretical framework putting all of this together. So I think what I want to first highlight is the orange below, which is the menopausal transition, which, as many of you may already know, it's a multi-year period that's characterized by declines in ovarian reserve and concomitant estrogen depletion, and takes place over many years. So looking at the premenopausal stage here on the left in the green, looking at the balance, it's balanced inflammation is what I would argue. So you have estrogen, which has some anti-inflammatory effects, and then the TLR7, which increases innate immune response. Whereas following the transition to menopause and in the postmenopausal phase, due to estrogen depletion, you have decreased the anti-inflammatory effects and similar TLR7 increasing in the innate immune response, which leads to increased inflammation. And this is a putative mechanism by which this may occur. So this is work from Sarah Gianella, which was also looking at work within the Max-Wise combined cohort study. And she was looking at inducible RNA across several reproductive stages, so premenopause, perimenopause, and postmenopause, and found that women, postmenopausal women, had higher levels of inducible HIV RNA compared to premenopause, and that inducible HIV RNA also changed over time and across the reproductive stages. Similarly, so Brandy Peter Samuelson, also working within the Max-Wise combined cohort study, found that menopausal status was associated with higher levels, certain markers of immune activation in women with HIV. So she looked at women both only with HIV in premenopause and then postmenopause, and found that compared to the premenopausal women with HIV, that postmenopausal women had higher levels of SED14, SED163, IL-6, and TNFR1. And this is just a figure on the right of SED14 specifically, and you can see the purple is the premenopausal and orange is postmenopausal, and there's higher levels of SED14. Last, I'd just like to show some of the work that I've done in collaboration with others within CNIX that's going to be presented at CROI this year. So building on the work by Sam Schnittman and others, we were interested in looking at inflammatory proteins and whether there are sex differences and differences by age. So what we found looking at, this was leveraging the Olink proteomic platform, inflammatory protein platform. We looked at sex differences and their association with mortality and stratified by age, using age 47 as a proxy for menopausal status. And as you can see here on the left, that there are some inflammatory proteins that were higher in women than in men when women were less than age 47. And some of those are associated with mortality. But then here on the right, when looking at those who are above age 47, you can see that there were far more inflammatory proteins that were higher in women than compared to men, and that many of those were associated with mortality, suggesting that sex differences are highly dependent on age, and there may be a menopausal effect as well. So in summary, there are important sex differences in aging-related comorbidities in people with HIV, that women with HIV appear to have higher levels of immune activation than men with HIV, even when on antiretroviral therapy. Sex hormones appear to play a role in immune activation, and age and likely menopause modify the effect of HIV in immune activation, and provides a potential mechanism for sex differences in aging-related comorbidities in people with HIV, although future studies, both including aging women and in transgender women, which I know we'll hear a little bit about more now, are needed. So thank you so much for having me. I'd like to thank specifically Dr. Tien and Dr. Hunt, as well as all the CFAR organizers and the CFARs.
Great, thank you, Dr. Abelman. We're going to hear now from Dr. Tonia Poteat. who's a professor in the School of Nursing at Duke University. Dr. Poteat is the co-director of the Duke Sexual and Gender Minority Health Program. Her research, teaching, and clinical practice focus on HIV and LGBTQ health with a particular attention to the health of transgender communities. Her research attends to the role of intersectional structural stigma in driving health inequities and seeks to identify strategies to advance health justice. Dr. Poteat is certified as an HIV specialist by the American Academy of HIV Medicine and a gender specialist by the World Professional Association for Transgender Health. So she's really an expert in HIV research and care with transgender persons. Also, I just wanted to mention that she co-leads the Inter-CFAR Transgender Health Scientific Working Group, and if you want to know more about that, I'm sure she can tell you how to sign up and be part of that group. So thank you so much for being here.
Thank you. And thank you to the last speaker who I didn't even meet, but introduced my topic very well. Thank you so much. So for the next 20 minutes, and I have a little timer to try to keep myself on time because I get excited and I talk a lot. I want to just have a quick review of key concepts around race and sex that underpin what I'm going to be saying about cardiovascular disease in transgender women living with HIV, outline what we know about cardiometabolic comorbidities among trans women living with HIV, outline some of the hypothesized drivers, and describe some of the gaps and opportunities, and then invite all of you amazing people who are looking for studies to do to dig into some of the data that's been collected. So I added these slides yesterday because my social science brain was exploding yesterday, and I just wanted to remind us that both sex and gender are socially constructed, right? I think everybody in this room is aware that there is multidimensionality to gender, right? People have a variety of gender identities, but people often forget that sex is also multidimensional. There are many layers of sex around chromosomes, hormones, internal and external anatomy, and all of those things are not binary within themselves, and they're not binary across each other. So I want us to keep that in mind, and that the fact that we categorize them into two different buckets is a social exercise. So binary sex itself is socially constructed. There are about 1.7% of the population that have non-binary sex traits, and approximately 2 million people in the United States who fit under the transgender umbrella, defined as having a current gender identity that's different from the sex assigned at birth. We good? I put some books there, so in case you're just that was a lot really quick, you can go and check out Ann Fausto-Sterling, who's really the leading researcher in this area. Also, race is a social construct. It has real impacts, but it is also socially constructed. We know that there's no fixed, coherent definition of race that's stable across time or place. We know there's no genetic basis or consistent traits, that some of the racialized traits like skin color vary within racial groups and across racial groups and overlap. It is not a proxy for ancestry, despite everybody going to get their 23andMe. It's not going to tell you what race you are. Right? And in fact, the National Academies of Science, Engineering, and Medicine published this beautiful report early in the year, really encouraging people who do this sort of genetic research not to use it as a proxy for race, because there's a lot of slippage there. Racialization is a social process. Each country and each community creates these social buckets that they put people in. And me, for example, in the United States, I'm considered black. When I go to South Africa, I'm considered colored. And when I'm in Senegal, I'm considered clear. So I'm the same person in each of those places, so racialization is happening as a social process. It does, in fact, racism, in fact, is what has these social impacts, not race. So that's my bucket that I'm coming from. Hope you all are with me still. And then we're going to dive into the topic. First, I just want to remind us of the incredible burden of HIV borne by transgender women. In general, the population has about 0.3% prevalence of HIV, but if you look specifically at transgender women, overall the prevalence is about 14%, and if you break it down by racialized groups, the heaviest burden is among Black and Latina trans women. 44% for Black women and 25% in a systematic review published by CDC a few years ago, and then the recent CDC National HIV Behavioral Surveillance Study that focused specifically on trans women, collected data in 7 cities, found an HIV prevalence of 42%, so very high. Then if we look at the largest data set of transgender women living with HIV, which is the Ryan White Care Program, They have about 11,000 transgender women who've received HIV-related services through Ryan White, and the largest proportion of those are 53% Black women and about 29% Latina women. So when we're talking about trans women living with HIV, we're predominantly talking about trans women of color. I had a lot of caffeine. Am I too fast? Are we good? All right. You're with me? Okay. All right. So given that burden of HIV among transgender women, what do we know about the burden of cardiovascular disease among people living with HIV? And these are data drawn from the CDC, very much drawn because I just took their whole slide and put it here. But then I added some things. If you look at the top 5 causes of death of people living with HIV in the United States, and the most recent data is from 2020, you can see that HIV is a leading cause of death across racial groups. And it is the top chronic disease cause of death among people living with HIV, among Black and white people with HIV in the US. This was a beautiful systematic review that was done gathering data from across different countries with 2 million people living with HIV included in the data set, and they found a 2-fold increased risk of cardiovascular disease among people living with HIV compared to people without HIV. And in the editorial that accompanied the Reprieve trial, which I'm going to talk about in a minute, they noted this disparity, this extra burden of HIV among people living with HIV, and that it was not explained by the existence of risk factors, and it was not mitigated by the successful antiretroviral therapy or viral suppression. So something else is going on. Who has not heard of the Reprieve trial? Oh my God, wait, yay! Okay, so I'm shocked. I feel like all I hear is the Reprieve trial. So Reprieve trial is a big randomized controlled trial among people living with HIV that randomized people to receive either placebo or pitavastatin, which is a cholesterol-lowering medication. And they enrolled people who were at low or moderate risk of cardiovascular disease, right? And they followed them over time looking at heart disease-related outcomes. I'm not going to go over that trial. What I am going to point out is that it is one of the few trials that explicitly ask about gender identity and sex assigned at birth and identified 126 transgender people in that data set. Super excited. And then some lovely human being who I don't know published baseline data set of the transgender participants in the Reprieve trial. And you can see for the most part, comparing across trans women, cis men, and cis women, we see some similarities. I do want to point out a couple of important differences. One is, I showed you the data showing that the majority of trans women living with HIV are Black, and you can see this is not reflected in the people who enrolled in the Reprieve trial, so keep that in mind. We don't have the results of that trial yet, specifically for transgender women, but when we do get those, I think this is going to be an important factor. I think that is also related to some of the non-differences that we see, and that some of the cardiometabolic risk factors are higher among cis women who are majority Black in the Reprieve trial. Did I say Reprieve trial? Compared to trans women. I think they also did a really important analysis among this subset of transgender women, looking at transgender women who were taking gender-affirming hormone therapy and transgender women who were not taking gender-affirming hormone therapy, and then comparing that to cis men. And they found that for trans women not on hormone therapy and cis men, they had the same waist circumference, same proportion of people who had a waist circumference greater than 102, which is a cardiometabolic risk factor, compared to almost double that among transgender women who were taking gender-affirming hormone therapy. Y'all still with me? Yay. All right. So that is just laying the foundation. There is unfortunately very limited data on cardiovascular disease risk and cardiometabolic disease risk among transgender women living with HIV. There's a growing body of data looking at transgender people related to cardiovascular disease, and a growing attention to cardiovascular disease among people living with HIV, but very little at that intersection. And these are some of the papers that have been published in the last few years. And we have the illustrious Jordan Lake, who's going to talk to us a little bit about this later. What I want to talk about is the fact that almost all of this research that's being done, all like 5 studies, have really focused on the impact of gender-affirming hormone therapy. How does gender-affirming hormone therapy affect cardiovascular disease risk, inflammation, atherosclerosis, all these other factors that we know are related to cardiovascular disease. However, I have the question, as a semi-social scientist, Are gender-affirming hormones the only potential trans-specific drivers of elevated cardiometabolic risk in transgender women living with HIV? Are they just, cis people with some hormones? I would argue no. If we look beyond the biomedical factors and we look at structural factors that put trans women at risk for being at risk for HIV, there's a lot to learn. One of the ways we can learn this is being outlined by some of the great work that's happening at the American Heart Association. Keeping in mind that the majority of trans women living with HIV are Black, I think this is a really relevant paper that was published in 2020. What this paper did was look at structural racism as a fundamental driver of cardiovascular health disparities. And you can see on the bottom left, they show cardiovascular disease mortality over time divided out by racial groups. And you can see it declined in every racial group, but the disparities remain the same, with African Americans having the highest cardiovascular disease mortality over all these time periods compared to other racial groups. And I think the beautiful thing that they did is they didn't just leave it there. Then they said, well, why? And they went all the way back to 1619 when the first enslaved Africans came to the United States and walked through how slavery led to structures of white supremacy and racism that led to post-emancipation continued structures of racism, Jim Crow, segregation, racial biases in judicial systems, how this concentrated poverty and social determinants of health within Black communities and led to these social drivers of cardiovascular disease inequities: poor access to health care, poor housing conditions and physical environment, poorly funded schools and inadequate education, and poor access to capital, which is another word for money, right? And these are things that lead to toxic stress, which I'm going to talk a little bit more about, and increased risk factors like smoking, alcohol use, things like that. So building on that, a few years later, a group of researchers, of which I will disclose I was one, published another statement through the American Heart Association about addressing cardiovascular health among transgender people, and built on this conceptual model of how do social drivers lead to cardiovascular health problems that we see in trans populations. If you start in the upper left of this diagram, you can see that we focused on macro and micro systems of stigma and discrimination. And you say, well, what do you mean by micro and macro systems of discrimination? In 2023 alone, over 591 bills have been introduced in the United States that are against providing gender-affirming care for trans people, against allowing schools to say the word transgender, against allowing transgender people to engage in sports activities that are consistent with their gender identity. 591. 85 of these have passed, 377 of them are active, and new bills are being introduced all the time. So there is literally a political attack on transgender people. Not surprising this is associated with a big spike in hate crimes against transgender people. And over time, this underlying discrimination and stigma that transgender people face has led to negative social determinants of health. So we see higher rates of unemployment leading to economic instability, food insecurity, housing discrimination leading to higher rates of homelessness. Trans youth who experience bullying in school are more likely to drop out and have lower educational attainment. Trans youth are sometimes kicked out of their homes or run away from homes because of how their lack of family support. And not surprisingly, in healthcare systems, people have difficulty accessing both primary care and gender-affirming care, leading to delays and lack of access to cardiovascular-related care and preventive care as well. So hopefully I've convinced you that this upper left-hand part of this graph, of this conceptual model, is actually what's being experienced by trans people in the United States. So these negative systems, this structural stigma and discrimination, leads to both a psychological stress response and a physiological stress response. And now I'm going to dive deep and give you the world's most complicated figure, which is probably saying nothing given that I didn't understand half of the last lecture that was given. But if you look at this adaptation of what's called the minority stress model, and you start in the top left, you can see that everybody experiences stress in their life. Like, life is stressful. We all somehow survived COVID. But for transgender women living with HIV, they live at the intersection of some very specific stressors related to HIV-related stigma, transphobia, sexism, racism, all of those things. And those specific intersections lead to stressors that go beyond the general stressors. Minority stresses like experiencing prejudice and discrimination, all of the things that I described on the prior slide. And this leads to proximal or internalized stressors like expecting rejection, trying to hide one's identity. And all of those things have physiological impacts on the body. In addition to those structural impacts like not having access to healthcare, people's body actually responds. There's a concept called allostasis. So when we experience stress in our lives, then we have a dysregulation of our psychoneurologic systems, right? Or immunologic systems. And then there's a recovery. And that's what happens for most people who have intermittent, long spaced out sort of stressor hits. But what about people who have repeated daily chronic experiences of psychosocial stressors? Then there is dysregulation of this system, which is called allostatic load, and leads to negative health outcomes. So in terms of cardiovascular disease, some of the psychological stress response leads to increased risk factors like smoking and things that we talked about, changes in diet and activity, but also makes physiological changes in blood pressure, in lipids, in glucose metabolism, and in vascular function. So hopefully I've convinced you. I'm happy to talk longer, but they only gave me 20 minutes, so I'm going to head towards the end here. Who's doing this research to provide the data to support this kind of model? I looked at NIH Reporter looking for transgender, HIV, and cardiovascular or cardiometabolic disease, and it yielded 18 active studies. So I was like, that's not so bad. And then I read the abstracts of these studies, and there were only actually 2 that were doing those things. One is Maybelle Toribio, who is at, I think she's at Mass General, but she's associated with Harvard, who's looking at cardiometabolic effects of gender-affirming hormone therapy. I don't know why Jordan's studies weren't there, but Jordan, I know, is doing this work. And then my study that's looking at specifically beyond gender-affirming hormone therapy, what are these psychosocial factors that link minority stress to HIV-related comorbidities like cardiovascular disease? The study is called Light Plus. You can see the amazing investigators I get to work with at Johns Hopkins, Brigham and Women's, Whitman Walker, at Fenway, and Callan Lord. And this study has enrolled about 102 Black and Latina transgender women living with HIV. Our goal is to follow them over the course of 2 years, looking at their experiences of intersectional stigma, their experiences of stress, stress biomarkers, and cardiovascular disease-related risk and outcomes. Our study aims are here, making those links as I described before, and really testing this chronic dysregulation as a mediator between experiences of intersectional stigma and cardiovascular disease outcomes. I also want to just put our study population up next to the Reprieve study population. And you can see that there's some significant differences. Our study population is a little bit younger, but our study population more accurately reflects transgender women living with HIV in the US, in that most are Black and most are on gender-affirming hormone therapy. A much lower proportion of the transgender women, I think it was about half of the transgender women in Reprieve were taking gender-affirming hormone therapy. And in my experience, closer to 80% is more accurate. And I think we also see some differences in the cardiometabolic risk factors for the people who were in this study compared to the people who were in the trans people who were in Reprieve. So I'm going to end just with we haven't completed data collection, but we have looked and analyzed some of the baseline data sets and really used it to hopefully try to drive some clinical changes. Many providers before the Reprieve study that says basically give everybody a statin used a risk calculator developed by the American Heart Association and the American College of Cardiology to estimate cardiovascular disease risk. And we know that these risk calculators underestimate risk for people living with HIV, yet they are still commonly used. And these risk calculators ask mostly biomarker data, but also ask for age, race, and gender. And we know that if you believe my first couple of slides, race and gender are social constructs, right? So it's taking into account a socially constructed race and gender as we're thinking about cardiovascular disease risk. And what does that mean when we are trying to calculate risk and provide information for people? part of what it means for those of us taking care of our transgender people is we don't know actually what they're asking when they ask the gender question. Are they asking about sex assigned at birth? Are they asking about current gender identity? Are they asking about hormonal status? What are they asking? And so it presents some challenges in trying to estimate and provide risk information for transgender women living with HIV. So that's where we are in terms of what I was able to find about cardiovascular disease among transgender women living with HIV. There are enormous gaps. There's lots of opportunities. I am happy to collaborate with any of you on the enormous amount of data that we're collecting and will probably not in a lifetime have time to analyze. So feel free to reach out to me if you're interested. We need longitudinal data on trans women and not a 5-year NIH study that allows me to follow people for 2 years. We need like Max Wise level 30 years of following trans women living with HIV. We need large data sets that are able to adjudicate cardiovascular outcomes, not just risk estimators or self-reported outcomes, but adjudicated outcomes. And we need validation of risk calculators that can help us have informed conversations with patients about what their risk is and what choices they have available to them to reduce their risk for cardiovascular disease. And importantly, we need to really think about the psychosocial and structural interventions that we could do to reduce risk for cardiovascular disease and many other health outcomes among people who exist at the intersection of multiple marginalized identities. We have opportunities. There's the Reprieve data set. I hope that they're going to do analysis of the transgender participants in that data set. The NA Accord and CNIX data sets have visibilized the transgender people in those cohorts, so there's opportunities for retrospective analyses there. And I hope, since there's 2 NIH people sitting on that panel, that NIH will consider funding longitudinal studies inclusive of transgender women living with HIV to look at comorbidities. So I just want to end by thanking all the amazing people who, without whom none of this could be possible, including the Scientific Advisory Board, Maybelle, Zachary, and Rob, graduate students, and the other workers in my lab. And I finished with 43 seconds to go. So thank you so much, and I look forward to the panel discussion.
Thank you so much, Dr. Poteat. And last but not least, we have Dr. Jordan Lake, who's a professor of medicine with tenure at the University of Texas Health Science Center at Houston. She completed both medical school and internal medicine residency at Baylor, followed by an ID fellowship and Master of Science in Clinical Research at UCLA. And Dr. Lake's outpatient practice focuses on adults with HIV, and her translational research portfolio focuses on the treatment of metabolic complications of HIV and antiretroviral therapy, including optimizing care for transgender women with HIV. And today she'll be speaking about ART optimization and cardiometabolic health in cis and trans women.
Thank you. So as Tonia just told you, we have such little data on trans women that I cannot give you a data-driven talk about how to optimize ART or cardiometabolic health. And a lot of the things that you just heard about in the previous talk really apply to how we will ultimately want to approach ART optimization and cardiometabolic health for trans women. But for this talk, we're limited in what we can talk about in 20 minutes. So I'm going to focus a lot on sex hormone physiology and how you may want to think about trans women and cis women similarly or differently. So if we're talking about sex hormones, what is the common denominator between cis women and trans women? And it's going to be estrogen or the lack thereof. But that's the simple answer. Of course, not all estrogens are created equal, particularly for exogenous hormones. The types of estrogens that trans women and cis women take have overlap, but by guidelines are quite different functionally sometimes. And then dosing regimens are often very different. So even if somebody's on the same type of estrogen, exogenally, oral contraceptives and postmenopausal hormone replacement therapy, we're talking about microgram to low milligram doses of estrogens, whereas in trans women often we're talking about very high dosing of estrogen. So that may not be physiologically the same, but again, we don't have good studies to tell us what the dose response might be, at what point the risk changes, so there's a lot to learn. And then there's much more data on clinical outcomes in cis women, so we have a better idea of what cardiovascular disease trajectories look like in cis women, and we, because of lack of longitudinal follow-up, we really don't know that in trans women. And then from a physiologic standpoint, in addition to all the other things that are going on in their lives, when you're giving estrogens to trans women, you're also androgen depriving them. So there's a huge literature in cis men on what happens when you give testosterone deprivation therapies. And so you have to think that you're also causing those cardiometabolic changes potentially. And then what's androgen deprivation and what's estrogen in trans women? Again, it will be amazing when we actually have data to help tell us that, but right now we're sort of flying blind. So the talk focuses a lot more towards trans women, since I primarily care for trans women, but for those of you who don't know, as opposed to more common use of conjugated estrogens and ethinyl estradiol in cis women, 17-beta estradiol is the preferred exogenous estrogen for trans women due to lower risk of cardiovascular side effects. But of course, especially when people are taking hormones in a non-medically supervised setting, they may be taking any estrogen with higher or lower cardiovascular risk. And then when we're giving trans women estrogens, we're trying to achieve a serum estradiol concentration around 1 to 200 picograms per mil, and that's per the Endocrine Society guidelines. And you can see, I don't know if this has a pointer, but on the pink, in the figure, the pink peak there is the peak of estrogen during the menstrual cycle for a cis woman of reproductive age, and so you're trying to get into that range. Some people will allow much higher estrogen levels. A lot of folks think the Endocrine Society guidelines are too conservative, but that is sort of the number that you hear tossed around 200 picograms per mil. If the participant, the patient wants that, a lot of how we drive hormone dosing in trans women is based upon what they want and how they're feeling about their hormonal regimens, and so that's another way that it's very different from providing exogenous estrogens to cis women. And then testosterone is often not suppressed. Ideally, you would totally suppress testosterone to less than 50 nanograms per mil, and that would be considered completely suppressed. I hesitate to say optimally, though, because again, it's different for every trans woman. If somebody needs or wants to maintain erections, we don't suppress their testosterone. Some trans women come in with very low endogenous testosterone levels. Others come in with very high. So where you end up testosterone-wise varies greatly. And we presented some data at CROI last year that suggests, though, that particularly for cardiometabolic health, the presence or lack of significant circulating testosterone levels may really have an impact on cardiometabolic disease burden. And so what I've kind of been leading up to is, are estrogens potentially acting similarly or differently? And Tonia already showed you about obesity in trans women, but we think a lot about body composition when we're thinking about how this may affect cardiometabolic health. And of course, gender-affirming hormonal therapies, you gain visceral fat, you gain subcutaneous fat, and you lose lean mass with both estrogen supplementation and androgen deprivation. And that's sort of the opposite of what you would expect for a cis woman going through menopause. Where withdrawal of estrogen is causing those same changes in body composition. So that's one way where things are very different. Obesity rates increase dramatically with GAT, and I'll show you a slide coming up, just the magnitude of that. But so rapid progression for some patients towards development of obesity, and then progesterones are really not highly recommended as components of gender-affirming care, but there are plenty of trans women on progesterones, and those really amplify these effects of exogenous estrogens. And then something I always warn my patients about is, while you may be wanting to gain weight or change your body composition in a way where you're mostly gaining weight in the breasts and the hips and the thighs, you're going to gain weight however your genetics tell you you're going to gain weight. So if everyone in your family only gains weight in their middle trunk, you are probably going to gain weight there, and that we know that is a higher cardiovascular risk way to gain weight. So we're not just, inducing the same body composition changes in everyone either. And then spironolactone, that's the anti-androgen that is most commonly used in the United States in trans women, and its primary action, of course, is to block aldosterone, but its secondary action is to increase glucocorticoid activity. And from other disease states what happens when you increase glucocorticoid activity. You increase metabolic risk, you increase visceral fat deposition, so we may be facilitating some of these metabolic changes in our trans women by giving spironolactone as the anti-androgen. But there just are not data to tell us whether that's a fear of mine or whether that's an actual reality. Another thing for cis and trans women both, I think, to be aware of is the risk of sarcopenic obesity. So this is primarily a phenomenon talked about in the geriatrics population, but it's getting more attention in people with HIV because we know people with HIV lose lean mass and gain fat mass at rates that are greater than expected for age. And then so, of course, you've just heard if you're giving GAT to trans women, you're going to be promoting additional fat gain and lean mass loss. And then for women going through menopause, the same types of changes. And so if you're already on this increased trajectory towards sarcopenia, by having HIV, are hormonal changes facilitating this? And we worry about this because sarcopenic obesity has been associated with a wide variety of poor metabolic outcomes, including mortality. So just taking like some individual cardiometabolic states. So we know from an HIV standpoint, both our cis and trans women are at increased risk of cardiovascular disease due simply to HIV plus or minus artifacts. And there are high rates of traditional risk factors in people with HIV. This is not surprising. But gender-affirming hormonal therapies bring with them about a threefold increased risk of CVD death with current use. And that's a little bit, again, different than what we think about with cis women, where you're giving postmenopausal hormone replacement therapy, and if you're timing it correctly, you're hoping to reduce cardiovascular risk in cis women. And then, like cis women, use of exogenous estrogens, particularly for those who are older and who may be smoking, increases risk of thromboembolic disease. And so these are data that are older, granted before 17-beta estradiol was really the standard. But it shows you, compared to matched cis women and matched cis men, the rates of cardiometabolic disease in trans women after they start hormones. And so you can see venous thromboembolism and pulmonary embolus on the top row, explosion of event rates, myocardial infarction, five-fold increase in myocardial infarction after starting hormones, similarly for stroke, and then obesity, basically almost 3 times, 2.5 times the rates of obesity associated simply with starting GAT, and those rates on GAT are greater than in their matched controls, whether they be matched cis men or matched cis women. So obesity is something we really need to think. I mean, we should be thinking about it for all our patients, right? But it may have different components in our trans women. And then lipid disturbances, again, you are all familiar with lipid disturbances related to HIV. When it comes to hormones, this is one way that GAT in trans women is more like menopause. So again, maybe the opposite of cis women, and that you get lower LDL, but you get higher triglyceride levels, and then anti-androgens, maybe giving similar additive or synergistic properties. For insulin sensitivity, we know HIV disrupts both hepatic and peripheral sensitivity, and then we know in our trans women on hormones, this is worsened by exogenous estrogen, it's worsened by testosterone deprivation, and then again, if you're giving progesterones, you may additionally exacerbate insulin sensitivity. For fatty liver disease, I'm sorry, I'm really speeding through this, but I want to make sure I don't take more than my time. Hepatic steatosis, it's not only a worldwide crisis, it's a crisis within people living with HIV, extremely common, and it's a more aggressive form of fatty liver disease than you see in the general population, with higher rates of progressive liver disease and higher severity profiles. And then how this varies by sex and gender is really unknown. We published some data from our own personal cross-sectional cohort, and the trans women in that cohort were more likely to have moderate to severe hepatic steatosis than the cis women. But again, we need good studies, we need longitudinal studies. We know in cis men that testosterone deprivation exacerbates hepatic steatosis, so you might expect that in trans women receiving exogenous estrogens. And then estrogen deprivation therapy also promotes development of hepatic steatosis in cis women. So this is a way, and menopause does too, so this is another way where hormones may be acting not, opposite or antagonistic is not really the right word. It's probably about balance of sex hormones and their effects, testosterone to estradiol ratios, for example. And then we know hepatic steatosis in cis women, excess testosterone is associated with increased risk, as you would expect with menopause. So in our trans women who do not have suppressed testosterone, is the amount of testosterone circulating an additional risk factor? Nobody knows. I'm not a microbiome expert, but something that I think is really interesting relates to estrogen, HIV, and the microbiome. So the gut microbiome regulates deconjugation of estrogen into its active forms, and so diseases that lead to decreased microbial diversity, like HIV, prevent deconjugation of estrogens, which lower estrogen levels, both for cis women and trans women. And so we know for cis women that the decreased estrogen levels, contribute to the development of metabolic disease with menopause. Is this also happening in our trans women related to microbiome changes? We don't know. We do know, again, from cis women that giving estrogen therapies increases microbial diversity and improves gut barrier integrity, which is a problem for our folks living with HIV. And estrogen can reduce LPS-induced inflammation, again, a problem for our folks with HIV. So could putting our cis and trans women on GAT and on HRT actually improve their HIV-associated microbiome dysfunction and inflammation? I would love for somebody to do that study, so please feel free. And then just some remaining questions, and this is my last slide. Related to all the conversations about weight gain on art and how cis women, particularly cis women of color, are more likely to have excessive weight gain on integrase inhibitors and tenofovir alafenamide. Will trans women on GAT also experience greater weight gain? We don't know that yet. And for trans women who achieve testosterone suppression, for those in whom that would be appropriate, are they going to see similar CVD benefits of estrogen-based therapy as cis women? And then these are actually the data we presented at CROI. We know that there are several cardiometabolic parameters in trans women that more mimic the menopausal transition for cis women. So again, what is androgen deprivation and what is estrogen? We don't know, but in this data from, we enrolled trans women in Baltimore and Houston, and we matched them very closely to cis men from the MACs. And here we go. Well, you can see that the TWT is trans women who still had total testosterone levels greater than 50 nanograms per mil, and TWS is trans women with suppressed testosterone. So compared to their controls, trans women who had suppressed testosterone did not have any non-calcified plaque, which is the plaque that is most likely to rupture and cause myocardial infarction, and they did not have any advanced coronary stenosis. Whereas the trans women who had detectable testosterone levels, and you can see here, they're basically the same as their cis male controls. They had similar levels of non-calcified plaque and similar levels of advanced stenosis. And so this was opposite, to some of the other things that we were thinking about, in that this may suggest a real protective effect of estrogen therapy for trans women. And the reason why the difference may be only for non-calcified plaque is, at least in this cohort, these are all trans women who experienced a male puberty before having exposure to hormones. And since it's plaque development and calcification of plaque takes decades, their calcified plaque volumes are likely to be plaque that was developed at a younger age before they had estrogen exposure, whereas newer plaque that would be non-calcified has been prevented by exposure to estrogen. So that's our working hypothesis, and we're hoping to follow up on this study because it's small. But that is my last slide. Thank you.
Terrific. Well, thank you so much for this tremendous set of talks. I want to open the floor now to questions. So we have a great amount of time, so please go to the mics with your questions. Okay. This is a partially formed question trying to link together some of the talks, starting with for all three speakers. We know that some exogenous hormones are impact inflammation and microbial diversity, especially in the genital tract. And so, trying to link that up with what Dr. Poteat and Dr. Lake showed about cardiometabolic diseases, and so in trans people, in trans women. Can you help me help us figure this out? And if there are interventions in terms of hormone decisions, especially with higher amounts of hormone being used and provided, how there might be intervention there that needs to be studied. You want to start, Rebecca?
Yeah, you start.
Well, I don't know, whoever can start. Do you understand what I'm getting at?
I don't think I understand the list.
Okay.
Can you clarify a little bit?
So there's a lot of data, and I'm glad to see people at the mic, so maybe this question won't work out, but there's a lot of data from cis women showing the impact of exogenous hormones, progesterone-based and estrogen-based, linking to changes in inflammation that are potentially increased susceptibility to infections, not HIV per se, but other STIs and things. And so then linking with the use of hormones for gender-affirming therapy in trans women, how, and the linkage that I think we're seeing between that and cardiometabolic diseases, is there something we can learn or something we can learn to study about the amount of hormone and the kind of hormone that's used for trans women that might actually change the risk for cardiometabolic disease? Is that better?
Yes, I think I understand a little bit more. I think a really important point and something that I'm really interested in looking at that may be related to all of these talks is thinking about the peripheral aromatization of estrogens that occurs in adipose tissue. So I think that's part of at least what I'm interested in looking at specifically in postmenopausal women and how that relates to body composition change. And I think that would be a really intriguing thing to look at in trans women as well, given the effect of looking at certain hormones and increase in BMI, which you would see in both transgender women and postmenopausal and premenopausal cis women. And that's often estrone and estradiol. And so I think that those may be potential targets. I don't know if that's getting at what you're looking at. So I think looking at different types of estrogens might be really intriguing, especially thinking about, I don't know as much about gender hormone therapy.
Right, and so then next, so what do you, from your work with the trans women, is this a relevant question, or, I mean, what do you think?
Yeah, sure. I mean, it's definitely a relevant question. Like, what the answer is,
We don't know.
Remains to be seen. And there's so many factors also that play in. It's all highly confounded. so it's difficult. But specifically related to inflammation, we will show some data at CROI that the glycomics of trans women on GAT with suppressed testosterone have aging and inflammation profiles that are much more similar to premenopausal women than either postmenopausal women or cis men. And this is all data from the MAX cohort and the group that I showed you that we had cardiac imaging on. But, you know, glycomics is only one part of all of the parts of inflammation. And so, you know, there are some things that are obviously different and perturbed in what we think is a negative way for trans women on GAT, and then there are other things ways that GAT may be beneficial. And again, it's almost makes my brain want to explode, like how are we going to figure out how it all interacts?
Yeah. And I just want to add that because we're looking at women who are older, most of them have been exposed to a form of estrogen therapy that is no longer recommended, conjugated estrogens, right? So we don't actually have really good longitudinal data of trans women who are on the currently recommended 17-beta estradiol. And if you're looking at data outside the United States, many trans women are taking oral contraceptive pills, which have a much higher risk of cardiovascular events. So we have a lot to learn. We have questions for your questions.
Yeah.
And we are going to be looking at, we have a small cohort of transgender women that we have from the CNX cohort that we're going to be looking at the proteomic data for. So I'm hoping to have some more information.
Okay, well, thank you so much for entertaining that question and helping dissect it and figure it out. Let's turn it over to you at the mic there.
Thank you for all those talks. I found each of them thought-provoking and could probably ask everybody a question, but for the sake of time, I can go ask Rebecca a question. One of the thoughts that crossed my mind during your talk when you were talking about the increased inflammation seen in women with HIV, especially in the context of comorbidities as well, makes me think about the way we do cure research for HIV. We tend to, I don't know what the demographics are between male and female, but one thing I am pretty sure of is, we tend to use very healthy, otherwise healthy people in these studies and whatnot, and with some exceptions. And the same for when they do the SIV studies. So I guess my question to you is, am I missing something, that this is an area of need that's really not being met yet? And if I'm missing it, inform me. And if I'm not missing it, what do you think the most immediate first steps to rectifying this would be?
Thank you for the question. It's very important. I would really like to highlight the work of Eileen Scully, who has been a huge advocate in this space specifically, and she's done a lot of advocacy in trying to actually recruit women for cure research. And she has done some studies looking at women specifically in cure-related studies. And what she's found is actually that we just have to try and recruit women, that's really the secret. And she basically adopted a very concerted effort in recruiting women and including them in cure research, and has done some studies looking at HIV cure and then also the effect of estrogen on HIV transcription. But it is still a huge knowledge gap and is very important. I hope that answers your question.
It does. Thank you.
Microphone over here.
Hi, thank you all so much for everything you're doing and for answering our questions. I have a question for Tonia and Jordan in particular. I was really taken aback by some of the research on health outcomes, like after starting hormone therapy compared with before, and comparing like matched, I guess it was cis men with transgender women. And at the same time, I was wondering how well matched do you think that those comparisons are when you were reading? And how well do you think confounders were controlled for? And I realize I'm coming to this with, one, a bias that I want everyone to just be able to get their gender-affirming hormones, but at the same time, I recognize that there's potential health risks involved. And then I think back also to Tonia's talk about just how much stigma and things that folks face that would be very hard to control for when you're comparing cis people with trans people. So I was just wondering what your thoughts are about the current research, and is there a better way to like control for all those things, or how do you think that we can piece all of this out?
I guess my first thought is like, I don't want anybody leaving this room thinking we're saying that trans women should not have access to gender-affirming hormone therapy, right? I think there are a growing body of data indicating it can be life-saving for people to have the support they need to live their authentic lives. So full stop there. I think what we all hope to do is help people do that in a safe and healthy way as possible. And I really appreciate your takeaway that yes, that comparing cis men to trans women is different not only because of what we assume is happening in their chromosomes, but because of their life experiences. And that's true for any study where you compare people, that it's impossible to control for every confounder, and you just have to take that into consideration when you think about the results. So I don't know if you want to talk to that.
Yeah, I mean, Tonia couldn't have said it better. My whole goal is that anybody who wants hormones should be able to have them, and like let's do it as safely as we can. And unless we do the research and unless we highlight risks and benefits, we're not going to be able to do it safely, and especially in the setting of HIV. And also, our patients should know that there are risks associated with this, right? We, like any medicine, we are not going into this without any risks, but defining those is different. And then, yes, it's always hard to pick controls. It's especially hard to pick controls for trans women because of lifetime experiences. The data you saw were from an older group of trans women. The mean age was around 50. And so again, like their life experiences and exposures are going to be very different than somebody who's starting hormone therapy today and looking at them 20 to 30 years later. So we just need a lot of data, and everybody needs to do the best they can. But I mean, in terms of a cardiovascular standpoint, those were matched on age, race, BMI, HIV serostatus, and ART type. So that's about as closely matched with small groups as we feel like we could get. And then the smoking status was similar and for both of the groups, so they didn't have to be matched on smoking status. But we try. That's all we can do is try.
Yeah, thank you so much.
Hi, everybody. So, great presentations. My question with Dr. Poteat, it isn't for you, but it's relevant to your presentation of race and gender as non-binary. And you really showed how the social and structural constructs impact biological expression with stress and cardiovascular health, right? So my question is actually for the NIH program officers in the room. When we're seeing a lot more justification of social and structural factors as root causes for biological expressions and health, do we see funding priorities reflecting that better understanding and nuances of root causes in your portfolios? Thank you.
I'll take that. I think the answer is yes, and I think we see it not only in our portfolios, but across the institutes at the NIH. I think there's a great sensitivity to this issue and an enormous interest, because we have to answer these questions. So it may seem slow on the uptake to you, but stay tuned. Watch this space. I think that we are going to see a lot more work and, of course, initiatives in this area, and appropriately so.
Grab a mic.
Can you come to the mic? That we are on mic.
Without repeating what Denise just said, because it is a trans NH, but there is, as I guess, data in support of this. RFA DK-25-001 is an RFA looking at 25 for the next year, and whatever. Google it. But we do have an RFA on syndemics, and syndemics impacting people with HIV and comorbidities. We are partnered with NHLBI and Office of Research on Women's Health, and it's basically it'd be comorbidities that are in the interest of NHLBI or NIDDK. So yes, we do have this interest, and we're putting money behind it with this RFA, which has a receipt date in March and a second receipt date the following March. So we're putting money behind it at least 2 years in a row.
Thanks, Peter.
Sorry to. But it's data that we care.
Right.
You can say you care, but where's the money, right?
Yeah, and as usual, we're giving you the homework to do. So we want your ideas to come in and educate us as well.
I have one question for Dr. Abelman. When you're thinking about inflammation, particularly in postmenopausal women with HIV, I'm wondering if you have data on differences in women who are on menopausal hormone therapy compared to those who aren't. If the argument is there's an imbalance between estrogen and TLR7, is there a change when you replace that estrogen?
That's a great question. I also have the same question. So no, we don't have that data yet. I think that it is a very important area. Similar to the gender-affirming hormone therapy, there's been a lot of research in hormone replacement therapy in women, and now there's different estrogens that are being used, and so there was a long precedent of reticence to provide hormone replacement therapy, and I think, especially in light of the results of the REPRIEVE trial, I think there's a lot of interest in what hormone replacement therapy can do for women with HIV and inflammation in particular, and it's something that I'm very interested in looking at as well. There's also an ACTG study that's going to be looking at some of this, but I don't know if they're looking at immune activation biomarkers.
Do we have any other questions?
So for Tonia and Jordan, based on the information that you shared with us today, I was wondering if you had any data, as some of these potential risks have been shared with trans women, if any of them had made perhaps different decisions about hormone therapy, or whether or not there's any data that's been collected about sort of how providers have talked about this, the kinds of questions that they get, and how they might respond.
I'm trying to make sure I understand your question.
Okay. So as you've talked about sort of the potential for things like cardiovascular risk and about weight gain and whatnot, and we were talking about the fact that, and I feel like both of your presentations sort of said, very clearly individuals should have sort of gender affirming care, but also we need to sort of remind individuals that there are no sort of medications without risk and without these potentials, and sort of trying to share what potentially could happen, right? So if that's the case, is there any data or have there been any studies about perhaps trans folks making a different decision based on understanding this information, or whether or not there's any data about providers having this conversation, the way in which they respond, and sort of the decision-making process around women in terms of gender-affirming hormones?
Okay, thank you for that. I have two answers. I'm going to start with the second one first, and that there, I think, is a huge potential for research, social science research, looking at patient-provider communication around gender-affirming hormone therapy. The most recent WPATH guidelines, the World Professional Association for Transgender Health, really strongly encourages an informed consent model, which many of us have been doing for a long period of time. And informed consent involves the word informed, right? So as we have data and information, we are sharing that with people as we make decisions together about their hormone therapy regimen. So I think that is something that happens on a regular basis when talking with people about gender-affirming hormone therapy. That said, I will say most people come to me already having taken hormones from their friends or from the internet or from somewhere else. So we're never starting from scratch about whether or not they're going to be on hormone therapy. It's about how we're going to do it and monitor it in a way that keeps them safe and making sure that they understand the risk and the benefits. So I don't know if you want to add to that.
Yeah, the only thing I have to add is just because historically lack of data, we also know that provider practices vary wildly, not only by geography, but providers within this, the same clinic, especially for some providers who have been doing it for many years. And, before, for example, there was a recommendation to monitor hormone levels, or that was even available at local laboratories. People want to sometimes do things the way they've always done things, and, new guidelines they're reluctant to take those. But even guidelines aside, it's how people are approaching this varies so widely that research is really needed. But I do, just like I think any patient population, I do have people who, when they hear about the risks, do want to modify what we're going to do with their hormones in response.
Okay, you can have our last question.
Okay. So this question is for Tonia, but is also a follow-up to Mandy's question about funding. And you were talking a lot about, structural racism and sexism and misogyny, and I'm really interested to hear your thoughts on how we can best go about studying that. And so I've done similar work, and I know it necessitates large-scale data sets where, people are across 50 states, ideally over time, and I know some data sets are starting to ask gender-related questions, but they're not necessarily oversampling for trans individuals. So I'd love to hear your thoughts on whether there are data sets or there are other data sets that could be leveraged to really answer some of these questions, to really get at those differences of, is it around race, is it around HIV status, is it around gender?
Yes is the answer, I think, to all of those questions at the end. But in terms of, I appreciate your point around oversampling and how important that is, even in representative data sets. But there are actually large data sets of transgender women in particular. I would call attention to the LIGHT study, which I didn't talk about, but was the parent study to the LIGHT Plus study that I'm leading. It's led by Andrea Wirtz at Johns Hopkins. And that study is being followed on by a study called ENCORE, which is also, the LIGHT enrolled about 1,500 transgender women, and ENCORE's goal is to enroll 2,000 to 3,000 transgender women. So there are large data sets that are national that are collecting these kind of data, and I think if people want to write administrative supplements to add biomarker data or anything like that would be very welcome, and I think it would be important, and I think NIH would support leveraging projects that they've already funded with large populations of transgender people to do this kind of work. Thanks.
Can I just very quickly add that just yesterday, a notice was published on an administrative supplement focused on understudied, underreported, and underrepresented populations of women from the ORWH. And so these are one-year administrative supplements. It's in the guide. Receipt dates it's due at the end of January. So that would be a perfect mechanism for Tonia's suggested analysis.
We did not plan this conversation.
That's great. Okay, well, we're right at time. So thank you so much to all of our speakers this morning for really getting us off with a great start. And we have about a 15-minute break now.